are at the annual meeting of the Menopause Society, formerly known as the North American Menopause Society. And I just heard a very interesting talk, and let me first ask you to just state your name.
Hi, I'm Dr. Amanda Black. I'm from the University of Ottawa, where I'm a professor of obstetrics and gynecology.
And I've had the privilege of interviewing Dr. Black in the past, and she always has a very good talk. And today she talked about something called Estetrol. And first of all, just very briefly, what is Estetrol?
So Estetrol, otherwise known as E4, is one of 4 naturally occurring estrogens. It is produced by the fetal liver during pregnancy, so it's found in maternal urine and serum during pregnancy. That's the only time you'll find it in adult life, and it's shown some promise for use in both the oral contraceptive pills as well as in menopause hormone therapy.
So I know it's been used as a contraceptive now, and it's combined with a less commonly used, but a progesterone type medication called, the name of that medicine?
Dyspareunin.
And what I want to focus on here is just its use in menopause. And right now it's not approved for menopause, but it has some very interesting qualities. I wonder if you could talk about some of those things.
Right, so you're absolutely correct. It's not currently available for use for menopause hormone therapy, but it shows a lot of promise. So one of the interesting things about it compared to other methods of contraception is how it works. Or other estrogens is how it works. So it acts on the estrogen receptor alpha at the nuclear level. So that means it has beneficial effects when it comes to bone, cardioprotective effects, etc. But it acts as an antagonist at the estrogen receptor alpha on the membrane level, which means that we don't see these same unwanted effects on the liver as well as on breast tissue or proliferation. And in fact, it inhibits the effect of the estradiol or E2 at the membrane level as well, so thereby also inhibiting breast effects and breast proliferation.
So it's protective of the breast, it's positive for the bones, and you also said it's helpful in the brain.
So it does seem to show that it, as far as the bone, that there's some benefits for that. With respect to the brain, we don't know for certain if that's the case yet. One of the thoughts is, well, why is it only in the fetus? Why was it only produced during fetal life? And we think, well, maybe it has something to do with neurodevelopment, but we don't really know. So we'll have to work on elucidating that further. So more to come on that, I think.
And are the studies that are available so far, do they suggest that it would be helpful for hot flashes?
Oh, absolutely. So we have the phase 2 studies that have been published that they show a significant decrease in both the severity as well as the frequency of vasomotor symptoms. In addition, they show a significant improvement in overall quality of life in menopausal women. So I think those are very promising. Similarly, the results of phase 3 studies, preliminary results, are available, which again show the same thing at doses of either 15 milligrams or 20 milligrams. So significant decrease in the severity and the frequency of vasomotor symptoms.
Are these medications available separate from the progesterone at this time? In other words, if somebody wanted just the Estetrol, 15 milligrams, for instance, could they get that?
No, not at this point. So at this point, Estetrol is only available as part of a combined oral contraceptive pill, so 15 milligrams combined with 3 milligrams of dyspareunin. It is not currently available on its own as menopause hormone therapy, but more to come on that.
Stay tuned. And what about the potential benefit of that for women in terms of worrying about breast cancer, or maybe those who have had breast cancer? Because there are women who do go back on estrogen after breast cancer. And what are your thoughts on that, realizing that this is not yet the facts?
Right, so I think there's very promising data both in vitro, in vivo, as well as in human studies demonstrating that it inhibits breast proliferation, and in some cases, for example, in a small study where they looked at women that had breast cancer prior to surgery, it induced apoptosis in the breast cancer cells. So that certainly has some promise there. If we're looking at, if someone's had breast cancer, is this the one that you can use? I think we still at this point would follow our guidelines for looking at either for contraception or in menopause, but it often comes down to informed consent and shared decision making. So if on the balance of risks and probabilities, this is going to be more beneficial to this patient because they're having such significant quality of life issues secondary to the vasomotor symptoms, maybe it is something that you could consider trying, but I would hesitate to say that's
right. It's
for
early
everyone,
still.
but I think it's still early to say that. But again, it's always an individualized approach when we look at.
But still, in tissue
therapy.
culture, in animal studies, and in human studies so far, there have been showing apoptosis or cell destruction in breast cancer cells. So that at least is encouraging for the future.
Well, it's certainly encouraging, and certainly encouraging from the point of view that we wouldn't be as concerned about the possibility of it increasing a risk of breast cancer.
Exactly. Okay, well, thank you so much for a really interesting talk and for taking time to talk with me today.
Thank you for speaking with me.